Hello everyone, welcome to KNO Academy. Okay, so in this video, we will discuss with high yield topics. So what we have said for the NORCET-9 high yield topics MCQ section plus also theory. Okay, so we'll move to the first question. According to new WHO guidelines, new WHO guidelines, what is the minimum number of antenatal visit? Okay, minimum number of antenatal visits recommended to the positive pregnancy. Suppose if woman becomes a pregnant, okay, so how many antenatal visits should be done? Okay, so that is option A is 4, okay, 6, 8 and 10. Okay, so there are 4 options. So the right answer is 8. Okay, I will tell you with the rationale how. Okay, as per the India, government of India recommends, okay, minimum 4. Okay, minimum 4. Government of India recommends minimum 4, but the WHO recommends minimum 8. Okay, I will show here. So this is the WHO guidelines. Okay, so that is first visit should be contact. First contact will be up to 12 weeks. Okay, then in the second trimester, okay, that is the 20 weeks and 26 weeks. In the third trimester will come with the fourth. Okay, that is the 30 weeks, 34 weeks and 36 weeks and 38 weeks and 40 weeks. Okay, this is the total number 8. Okay, 8 antenatal visits. Okay, that is antenatal, so we call ANC. Okay, so hope you understand. Suppose if she is not delivered at the 41 week, she has to visit. Okay, 41 weeks, completion of 41 weeks also not delivered means she has to return to the ANC. So this is the minimum number of antenatal visits should be done as per the WHO guidelines. Okay, suppose if government of India asked, we need to answer 4. WHO means we need to answer 8. Okay, don't confuse. Then question number 8. Which of the following is not a LARC method? Okay, LARC method of family planning. So LARC means long acting. Okay, long acting reversible contraceptives. Okay, long acting reversible contraceptives. Okay, we'll see one by one. Okay, injection Depo Provera. Okay, then subcutaneous implants, then Mirena, then OCP. Subcutaneous, sorry, injection Depo Provera. Depo Provera, that is we call Antara. Okay, I will show you the image. This also asked in the NORCET 8. Okay, NORCET 8, they have asked the question. Okay, Depo Provera. Okay, so Depo Provera is we are giving every 3 months. That is the Antara, every 3 months. Then subcutaneous implants, that is the will come with the name Implanon. Implanon, Nexplanon. Okay, come with the brand names. That is we are giving up to 3 years. Okay, this subcutaneous will give up to 3 years. Then we'll come to the Mirena. Mirena is a hormonal contraceptive. Okay, that will up to 5 years. Okay, so this is also 5 years, this is 3 years. Okay, so this is Depo-Provera is 3 months. Okay, then subcutaneous implants will be 3 years, then Mirena will be 5 years, then OCP we are taking daily. Okay, so hope you have cleared with this. Okay, Mirena we are giving daily, so that's why this is not a LARC, means long acting reversible contraception. This is not a long acting. Okay, so all injections and subcutaneous implants are the long acting reversible contraceptives, but except OCP. Okay, we'll see with the, see, this is the Depo-Provera injection. This is from the brand name. Okay, from private. Okay, that is medroxyprogesterone acetate. Okay, this is the 150 mg per ml will be there. Okay, this is same component only. Okay, but with the brand name Antara program. Program name is Antara. Okay, so this is the government supply. So who are all working in PHC, okay, and government hospital, they would have know this. Okay, this is the Antara program. Content is same only. Okay, then we will move with the Mirena. Okay, Mirena is the hormonal intrauterine device. This is the hormonal. I already told you hormonal IUD. Okay, so actually it contains 52 mg of, okay, levonorgestrel. Okay, 52 mg of levonorgestrel it has content. Okay, so this is the hormonal intrauterine devices. Okay, so how it will act? It will act like a, see, it will release 21 microgram mcg, 21 microgram of levonorgestrel per day. It will release, okay, in the uterine cavity. Okay, so how it will act? Okay, so action, mode of action is thickens the cervical mucus. Okay, then inhibit the sperm movements. So you can take a notes also. This contraceptives 100% one question will come. Okay, but in this NORCET-8 they have asked in prelims also, in mains also, around 2 to 3 questions. Okay, and thinning of the uterine lining. So this is the mode of action. Okay, so this is a Mirena is a hormonal contraceptive. Okay, used up to 5 years. Okay, we'll move to the next subcutaneous contraceptives. Okay, implants. So this NORCET-8 they have asked this birth control implant. Okay, so what it is usually? So it is a uh, see, it is a synthetic progestin. Synthetic progestin hormone. Okay, so like levonorgestrel. Okay, or one more composition will come, that is etinogestrel. Okay, etinogestrel. Okay, that in, for example, in implanon, I told you know in the previous slide, implanon, this contain etinogestrel. Okay, same, this is the mode of action same only, that is the preventing the ovulation, thickening the cervical mucus and thinning of the uterine lining. Okay, so it will help in the prevention of pregnancy. So this contraceptives, that is a subcutaneous implants. Okay, this is up to 3 years we can keep. Okay, see in the arm, that is the inside the arm, inner side of the arm. Okay, we can place here. Okay, so hope you understood. We'll move to the next slide. Which of the following is wrongly matched? This is the AIMS favorite question nowadays. Okay, which of the following is wrongly matched? So match the following and wrongly matched is the, so around 5 to 6 questions asked. Okay, in both prelims and mains. Okay, so they have given some conditions and the actions. Okay, everything. Okay, so option A, methanol formigipole. Okay, that is the methanol formipizole is the, see, we can see easily, we can find out that this is a antidotes, drugs and their antidotes: heparin, protamine sulfate, diazepam. Okay, sodium nitrate, this is not the right answer. Okay, warfarin, phytonadione is a vitamin K. These are the another name of vitamin K is the phytonadione. Okay, methanol is the always, homopizole is the right answer. Okay, this is also right answer. Okay, then what is the exact antidote of the diazepam? So diazepam is flumazenil. Okay, diazepam antidote is the flumazenil. Okay, Then like this also we can see lots of antidotes, dozen lot of antidotes we can see. Okay, so I will also give you one antidote video also. Okay, don't worry. And we'll move to the question number 4. Which of the fetal deceleration? Okay, deceleration. So from the CTG, always they will ask the question. I will tell you. Okay, around 5 to 6 questions, both prelims and mains. Okay, combined I'm telling. Okay, which of the following deceleration is seen in CTG during the head compression? During the labor, it has been. Okay, so head compression is always early deceleration. Okay, so for how to remember this? Okay, so we have made a wheel chop. Okay, wheel chop, and also mine I will tell you. So for the CTG with graph I will take a, okay, one more class. Okay, don't worry, I will finish it. So maybe they'll ask with the CTG graphs. Okay, and they may ask what is this. Okay, don't worry, how to read the CTG we will take another class. Okay, so in this video we're going to explain only wheel chop. Okay, so I will explain here. Okay, wheel means, see, v means, see, from first letters we have taken. Okay, wheel means variable deceleration is always related with the cord compression. Then what to do, action is mine. Okay, what to do, that is we have to reposition the mother, or we can move the mother. Okay, then early deceleration, I told you head compression, okay, will cause the early deceleration in CTG. Okay, so for that we need to interventions not necessary actually. Okay, if mother moves means it will go out. Head compression. Okay, then acceleration is okay, always acceleration is okay, no interventions required. Okay, then late deceleration is placental insufficiency. This is very very severe. So here we need to evaluate. Okay, we need to evaluate. Okay, we need to stop the oxytocin. Suppose if the case scenario, if they ask, okay, oxytocin is ongoing, so we need to stop the oxytocin. Okay, oxytocin, pitocin, both are same. Syntocin, okay, both are same. Okay, then we need to administer O2, oxygen. Okay, then we need to reposition the mother. Okay, then if possible, better to take C-section. That is the cesarean section we can take. Okay, then this is very very beautiful question. Identify the below medical condition. So by looking this we can easily say this is a neural tube defect. Neural tube defect. Okay, so options are myelomeningocele, meningocele, anencephaly, and meningitis. Okay, so here we can see there is a protrusion of both spinal cord and the nerves. Okay, both spinal cord and the nerve ending. So this is always myelomeningocele. Okay, in meningocele what happened I will tell you. Okay, so this is actually always severe form of the spina bifida. Myelomeningocele is the always severe form of, okay, spina bifida. Okay, so it may cause the physical disabilities and also neurological problems. Okay, so part of the spinal cord and its coverings protrude through the opening in the spine. Okay, so that is a baby's back. We can see the sac. So this is the sac. So suppose if baby suffering born with the myelomeningocele, we need to position with the prone position. Okay, to prevent the further injuries. So management always will be surgery only. So I will show here. So what is the normal and what is the abnormal spinal cords? Okay, so this is the normal spinal cord. This is the normal one. Okay, here you see that is the spina bifida occulta. Here what happened? There is no bone. One bone is missing here. So tough hair. We can see here the tough hair. So one small dimple will be there. In that hair will be grown. Okay, that is the, okay. But in the meningocele, you can see here always anyway bone is missed and a sac is formed. Okay, but this sac is filled with always CSF. Sac is filled with CSF. Okay, then this is Myelomeningocele. So I told you already, this is also protruded with the spinal cord and the spinal nerves. Okay, but in meningocele only CSF will be there. Okay, there is no spinal cord or nerves. Okay, in the meningocele. Okay, so this is the spina bifida occulta. Okay, spina bifida occulta. I told you, no, they see here there is no. This is the lumbar spine, so there is no bone here. So bone is there, but in middle there is no bone. Okay, so like here also you can see there is a gap. Okay, there is a gap between the spinal cord in the vertebral column. Okay, then question number 6. According to Richard regime, what is the dose of magnesium sulfate to prevent the eclampsia? Okay, this is very beautiful question. All NORCET. Okay, all NORCET. One question fix with the magnesium sulfate or with eclampsia. Okay, so see these questions we have prepared to give you the high yield topics. Okay, so in this only we will cover everything. Okay, so this is IV 20% of magnesium. Okay, 5 gram, option A, and option B is the IM 20% of magnesium sulfate 4 gram. Then IV, okay, IV 20% of magnesium sulfate 4 gram. Then IM 20% of magnesium sulfate 5 gram. Okay, so we have a beautiful picture. I will tell you. First, see, injection magnesium sulfate 1, write down. Okay, injection magnesium sulfate is come with the 2 ml will be there. One ampoule contains 2 ml will be there. Okay, suppose one ampoule 50%, we have to take a 50% also available, and also 25% ampoules also available in our practice. Okay, so for the eclampsia patients we need to take only 50%. Okay, injection magnesium sulfate 1 ampoule contains 2 ml with the 50%. This ampoule we need to take. Okay, this sample we need to take. Don't take the 25%. Then how to do this? 1 ml, sorry, 2 ml will be there, concentration will be 50% of the magnesium sulfate. How much we have to take? That is the loading dose as per the Richard regimen. Okay, loading dose will be always 14 gram. Okay, I will tell you how 14 gram. So in that 14 gram, okay, 4 gram will be IV. Okay, that we need to make a 20%. Okay, from 50% to 20% we need to convert. I will tell you how to convert. Okay, then 4 gram will be IV and another 10 gram will be IM. That is like how each buttocks 5 gram, 5 gram each buttocks, like, okay, just imagine. So this buttocks 5 gram and this buttock 5 gram IM we are giving. This is without dilution. This 20% 4 gram IV will be diluted. So how we are going to dilute? I will tell you. Okay, 50% means 4 gram means we have to take 4. Okay, 50% means 1 gram will be there. I forgot to tell you 1 gram. 1 ampoule contains 1 gram, 50% and 2 ml. Okay, so we have to take 4 ampoules. 4 ampoules, it means around how much? 8 ml. Okay, 8 ml will be there. In that we need to add plus 12 ml of NS. Okay, it will be 20 ml. So this has to given slowly, 20 ml slowly. Okay, over 5 to 10 minutes. This is the loading dose. So it will become 20%. 20% is equal to 20 ml slowly over the 5 minutes we have to give. So magnesium sulfate, don't confuse, always 20% means here I'll show, okay, 20% of MgSO4 4 gram IV. Okay, this is the right answer. Plus in this, if they asked, plus 10 gram IM. Okay, each buttocks 5 gram, 5 gram plus 5 gram is equal to 10 gram. So don't confuse. The total loading dose will be 14 gram always. This protocol posters we have already shared in the our groups. Okay, if you want, once again we will share in our NORCET group. Okay, total loading dose will be 14 gram. Okay, in that 4 gram will be given to IV. Okay, another 10 gram will be further divided into 5 gram plus 5 gram each buttocks we are giving. Okay, so hope you have cleared. If you have any doubts, you can also comment and you can also ask. Okay, in our groups, WhatsApp group, you can ask. Okay, and what is the classification of below drug? So this is amino caproic acid injection, that is the hemostat. Okay, amino caproic acid. Okay, so they have many times they have asked with the drug actions. Okay, this is not a thrombolytic. This is not a thrombolytic. Okay, this is not a antiplatelets, and this is not a anticoagulant. This is a antifibrinolytic. Okay, antifibrinolytic. So this will be administered in the acute bleeding disorders. Acute bleeding disorders. Okay, when suppose whenever the elevated fibrinolytic activity in your body. Okay, elevated fibrinolytic activity. That time we are using this amino caproic acid. Okay, this is the antifibrinolytic. Okay, don't confuse. We'll move with the question number 8. Which of the following contraceptive method has low Pearl index or least failure rate? Okay, so Pearl index is very very important. So compulsory one question will be there. What is Pearl index? Okay, Pearl index is it is a statistical measure. Okay, used to assess the effectiveness of a contraceptive method. Okay, it is a statistical measure used to assess the contraceptive method effectiveness. Okay, so suppose how it will be. See, lower Pearl index, lower Pearl index means contraceptive is high efficacy, high effective. Suppose higher the Pearl index, okay, higher the Pearl index is equal to low effective. Okay, this is the Pearl index. So I will show with the proof. Male condom is there, copper iode is there, male sterilization is there, female sterilization is there. So female sterilization is the Pearl, okay, na lowest Pearl index. Okay, female sterilization. I will tell you how much percentage is there. Okay, see, first we'll see the formula, that is the Pearl index formula. Pearl total accidental pregnancies divided by total months of exposure into 1200. 1200 is a number of months in the 100 years. 100 into 12 they have made. Okay, that is they have made like this, 100 into 12. That is the so formula also they may ask. Okay, you can write down total accidental pregnancies divided by total months of exposure into 1200. Okay, here we can see, see, male condom is a 18% of Pearl index. Okay, 18% is there, and here copper T, that is copper T is up to 0.8 percentage. Copper T is 0.8 percentage. This image I will share you, don't worry. Then male, okay, sterilization vasectomy is 0.15 percentage, and female is only 0.5 percentage. So this is the least Pearl index. Okay, so always the best method is female sterilization. Okay, this image I will share you, don't worry. Then what is the dose of levonorgestrel? Okay, levonorgestrel after unprotected intercourse. Suppose, so we call it as emergency contraceptives. Okay, what is the dosage they asked? Okay, as per the government of India, as per the government of India, I will tell you. So this is not a single dose of 0.75 mg, This is also not 1 mg also we are not giving. So this is the right answer. I will tell you how. The first dose 1 mg and after 12 hours, and this is also no. Okay. So the right answer is first dose of 0.75 mg. Okay, as soon as possible, but it should be before 72 hours. Okay, and after 12 hours, again 70.75 mg we need to take. Or else one more option is there. We can take 1.5 mg single dose, or same again 0.75 0.75 plus 0.75. This is what Government of India recommends in Ministry of Health and Family Welfare guidelines. It is there. Okay, so this is the dosage. 100% question will come. Okay, and next question: the following vacutainer is used for the estimation of dash. Okay, so this is the EDTA vacutainer. Okay, who are all worked in hospital, they might have know this. Okay, what is EDTA? That is the ethylene, and right here, ethylene diamine tetra acetic acid. That is the EDTA, ethylene diamine tetraacetic acid. Okay, so EDTA is a common anticoagulant. Okay, that prevents the blood clotting. Okay, it is used in the pink top. Okay, pink or purple color. Okay, so HbA1c or CBC, all investigations will send from this CBC. Okay, complete blood count, CBC. Okay, HbA1c. Okay, platelets, any counts we are sending through EDTA. Okay, and blood glucose level, from which I will tell you PTINR. Okay, blood culture. Okay, we'll see with the picture. See here, we can see all we have collected all the tubings. So yellow one we have seen, I think. Okay, yellow is a serum separator tube. That is a gel will be there inside, that gel will be there. That is a serum separator gel. So all biochemistry. Okay, all biochemistry. Suppose if you want any serum, so we can send this. Okay, all serum. Then heparin is for chromosomal studies, led to amino acids and troponin. Okay, propti. Okay, we are sending from the heparin tube. That is the green color. Then gray. Okay, sorry, black. Has a gray. Okay, gray is the fluoride or oxalate we call. Okay, fluoride, that is we call the blood glucose. Okay, then EDT I have already told you, CBC, ESR. Okay, C3, C4, HbA1c, homocysteine, ACTH, all things will be from this tube. Then plain, red is the always plain. There is no additives in this. There is no additives. Okay, LDHO. Okay, CA, drugs also. Okay, for the drugs, normal values. Okay, that we are sending through this tube. Like example, lithium, phenytoin. Okay, we are sending through this sample. Then blue is the sodium citrate. Okay, sodium citrate we are always sending with the coagulation testing, that is a PTINR, APTT, D dimer, etc. Okay, in this tube one mark will be there. Okay, there is a mark. Up to that mark only we have to take the sample. If you are taking 1 millimeter high also, 1 millimeter less also, it won't be, results will come far. Okay, so always take a accurate amount of blood in the blue tube. Okay, one more thing, ESR tube also, though we are sending the ESR. Okay, then we'll move to the question number 11. The nurse should avoid which of the following vaccine in a client with eggs allergy? Okay, so now question came from vaccine. Eggs allergy, which vaccine should be avoided? Okay, so not a pentavalent, not a rotavirus, not a HPV, which is always influenza virus vaccine. Influenza. I will tell you. Influenza vaccines are often grown in chicken embryo cultures. Okay, chicken embryo cultures. Okay, so they are growing the influenza vaccine from this culture. Okay, So it may contains small amounts of egg protein. Okay, so 100% vaccine will be contain the egg protein. So that's why we need to avoid influenza vaccine in the who are allergic to the egg vaccine. Sorry, egg allergy. We need to avoid the influenza vaccines. Okay, this is a new type of question. It may come. Okay, so we'll move to the next question. Which of the following electrolyte imbalance seen in chronic pancreatitis? Okay, which of the following electrolyte imbalance seen in chronic pancreatitis? Hyperuricemia, hyperkalemia, hypocalcemia, hyponatremia. Okay, so always hypocalcemia. I will tell you how hypocalcemia is related with the pancreatitis. Okay, so suppose what happens if your pancreas is affected. Okay, so pancreatic insufficiency will be there. It lead to impaired calcium absorption. Impaired calcium absorption. Okay, so malabsorption in what happens in case of pancreatitis. Okay, all fat soluble vitamins. Okay, malabsorption of all fat soluble vitamin. Okay, including vitamin D. So vitamin D is essential for the calcium absorption. We all know. Okay, vitamin D is essential for the calcium absorption. So that's why hypocalcemia happening in the pancreatitis. Okay, so we'll see with the hyperuricemia. Hyperuricemia is related to the gout or kidney disease. Okay, so this is not related to the pancreatitis. Then hyperkalemia also this is related with the any kidney disease or any adrenal insufficiency or some medications. Then hyponatremia also. Okay, hyponatremia it is seen in heart failure or liver diseases or any excessive fluid intake. Okay, excessive fluid intake. Okay, what happened? Okay, excessive fluid intake means so sodium dilution will be there. Okay, then hyponatremia will be there. Sodium will be diluted. So this also we will take a one beautiful class with the what is fluid and electrolyte imbalances. Fluid and electrolytes imbalances we will take class. Okay, so now it's clear pancreatitis is always related with the hypocalcemia because of malabsorption of fat soluble vitamins. So impaired calcium absorption will be there. So that's why hypocalcemia will happen in the pancreatitis. Then question number 13. Following intrauterine devices provides protection against pregnancy for duration of dash how many years? So who are all working in PHCs or government hospitals, they might have see these. Okay, this is the IUD copper T 375. Okay, I will tell you what is 375. This is for 5 years. This is for 5 years. Government of India supply. This is the government of India supply. This is the 5 years. It will come up to 5 years. I will show here down. Okay, see here we can see currently there are two types of copper T are available under the national program. This is very important. Okay, this is the copper T. Okay, one is copper T 380A and that is one more 375. Okay, this is for 380A is for 10 years and 375 is for 5 years. Okay, for this needs kill. Okay, 380A we need to load and we need to insert, but this is loading is not required. Okay, this is the 375. This is for 5 years, this is for 10 years. Okay, this is for 5 years. What is 375 and 380A? This is the surface area of the copper. Surface area of the copper. Then how it will act? Okay, copper ions released from the IUD. Okay, whatever we have inserted in the uterine cavity, so they have released the copper ions. That copper ions disrupt the for mobility and viability. Okay, and also make it difficult. Okay, it won't reach the fertilized egg. Okay, and also copper ions make the uterine line thinner, thinning of the uterine line, thinning. Okay, so and also it will not allow for the implantation, won't occur. Sometimes this IUCD also we can take it as a emergency contraceptive also in many cases. These contraindications and everything we will describe in next video. Okay, so it won't allow for the implantation. Then we'll move with the question number 14. All are used as an emergency contraceptive methods except. Okay, all are used as an emergency contraceptive except. So levonorgestrel, anyway, we are using this. Mifepristone also we are using. This is omeloxifene, we are not using. Okay, progesterone only pill we are using. Okay, what is this? Omeloxifene is a anti-estrogen, anti-estrogen drug. Okay, used for the treatment of breast cancer. Treatment of breast cancer. Okay, so this is the right answer. We are not using it for the emergency contraceptive. Then question number 15. The dose of epinephrine in a patient with asystole. Dose of epinephrine in a patient with a asystole. That is, so they have asked here, okay. Option A is 0.6 mg every 3 to 5 minutes. No. 0.5 mg every 3 to 5 minutes. No. 0.1, 1 mg every 3 to 5 minutes. Yes, right. 1 mg not. Okay, I will tell you here with the proof. See here, this is the AHA guidelines. AHA guidelines. So I will share this image to you. Okay. Here it is given. Okay. Epinephrine 1 mg. Okay. Repeat every 3 to 5 minutes. Okay. Here it is mentioned. 3 to 5 minutes 1 mg. Okay. Hope you understood this. Okay. This emergency critical care also we will take one more classes. Don't worry. Okay. So the right answer is 1 mg every 3 to 5 minutes. Okay. Question number 16. Which of the following is not a part of VAP, ventilator associated pneumonia care bundle, VAP bundle? Okay, this question asked in NORCET 4. Okay, maybe NORCET 10 also, NORCET 9 also, definitely they will ask. Okay, so they are always targeting regarding the clinical exposures. So who are all having the good clinical exposures, definitely they will crack the exams. Okay, who are all working in ICU. Okay, definitely know this. Okay, that is the VAP bundle. Now we call it as VAE, ventilator associated events we call. Okay, so VAP bundle is there. So I will show you and also I will share the picture also. That good picture is there. I will send you. That we have already shared in our 2022 only. We have shared in our Telegram channel. Okay, it is there. Okay, so now option A, head of bed elevation at 30 to 45 degree. Yes, this is there. DVT prophylaxis. Yes, this is also there. And daily assessment of readiness of weaning. Yes, this is there in the VAM bundle. We need to assess patients always, regularly. Okay, daily. We need to wean off the. We need to stop the sedation and we need to assess the patient. Yes, whether ready to extubate the patient or not. We need to check that. Antibiotic prophylaxis. No, this is not the criteria for the VAP bundle. Okay, see, we'll see. So this is a one hospital. This one. Okay, and this is the old one. I will take a printout of this. Okay, don't worry. So first line is daily assessment of readiness to win the buffer. Yeah, this is the first point. Then second point. See, what are the criteria involved in the VAP bundle I'm telling. Okay. See, I told you VAE, that is the ventilator associated events. Then head and elevation of 30 to 45 degree. Yes. Then daily sedation free interval. Yes. Daily sedation free interval because we need to assess the patient. Then blood sugar maintained below 180. Yes, this is also 100%. Okay, peptic ulcer prophylaxis. Yes, this should be there. Then chlorhexidine mouthwash. Okay, those above 10 years of age. This is the each shift we have to do. Each shift. Okay, chlorhexidine mouthwash. Then intermittent closed suction. Yes, CDC always recommend the closed suction only because of open suction always causes the infection. So closed suction is always better. Okay, then monitoring ET cuff pressure. ET cuff pressure also very important. They have asked in many exams. Okay, so this is the WAP bundle. Then question number 17. Which of the following is not intervention under Anemia Mukt Bharat? So this is very beautiful questions in this NORCET 8. Okay, around 5-6 times questions they have asked in prelims also and mains also. And also previous all NORCET Anemia Mukt Bharat 100% one question will be there. So don't skip this. Okay, Anemia Mukt Bharat 100% question will be there. Okay, then we'll see which of the following is not a intervention. This is which of the following is not an intervention. So I will tell you. They asked in the NACET 6 into 6 into 6 strategy. Okay, in which program they asked? Okay, this is Anemia Mukt Bharat. That is the AMB, Anemia Mukt Bharat. Okay, so we'll see the options. Prophylactic iron and folic acid supplements. Yes, this is there in the our Anemia Mukt Bharat. And deworming the by albendazole. Yes, this is there. And delayed umbilical cord cutting. Yes, this is also there. Okay, I will tell you how to cut the umbilical cord. Then D. Anemia. Testing of anemia by using the manual methods. No. Anemia Mukt Bharat recommends digital methods. Okay, digital tools. Okay, so that's why the right option is testing of option D is the right answer. So what is the 6 into 6 into 6 strategy? That is the 6 interventions. Okay, 6 target people. Okay, no, 6 target people and 6 institutional mechanisms. I will explain you. Okay, so this is the 6 6 into 6 into 6 strategy. This I will this image I will share you in the group. Okay, but I have made a separate slide. Okay, what are the 6 different beneficiaries we will see. This also they can ask in the upcoming exams. Okay, who are the beneficiaries comes under Anemia Mukt Bharat because they are asking every nurse one question they are asking from the Anemia Mukt Bharat. Okay, this question they have not asked. Maybe they'll ask in the upcoming exams. So, children aged 6 to 59 months. This is very important. Okay, month very important. They may confuse with this number. Okay, then two is the children aged between 5 to 9 years and adolescents aged between the 5 to 19 years. Okay, and women of reproductive age 15 to 49 years and pregnant women and the lactating women. These are the 6 beneficiaries, means 6 target people. Okay, this also I have told you in the high yield topics video. Okay, Anemia Mukt Bharat. And next, what are the 6 interventions we'll see? Prophylactic iron and folic acid supplementation. Yes. Then deworming. Deworming by the albendazole. Okay, and one more question. National Deworming Day. National Deworming Day. They have asked twice. Okay, they have asked twice, both in prelims and mains. Okay, so biannually we are celebrating in India, conducting biannually. That is the 10th February. Don't forget. Okay, 10th February and 10th August. Okay, this is the National Deworming Day. Okay, dates don't forget. National Deworming Day, 10th February and 10th August. Okay, and one more thing. Third point is the intensified year-round behavior. Okay, change communication campaign. Okay, solid body, smart mind. I will explain it. Okay, next slide. I will explain this. Intensified year-old, okay, behavior change communication campaign. I will tell you, okay, and testing and treatment of anemia. So using the digital methods, I told you, no, using the digital methods and point of care of treatment, okay, and mandatory provision of iron and folic acid fortified foods. So this is also six intervention. And one more, intensifying awareness, screening, treatment, and non-nutritional causes of anemia in endemic pockets. Okay, so these all are the six interventions. Okay, and we'll see. I told you, no, intensified year-round behavior change communication campaign, that is a solid body and smart mind. So this is, there are 4 points are there. I will tell you: improving the compliance to iron, folic acid supplementation and deworming. Okay, and appropriate infant and young children feeding practices. Feeding practices should be carefully monitored. Okay, especially in the primary mothers. Okay, primary, because they don't have knowledge of breastfeeding. Okay, and in village settings really they are very worsen. Okay, so we need to start the feeding practices from the antenatal period. Okay, I will tell you in the antenatal care. Okay, OBG classes are recording, I will tell you in that. Okay, then increase the intake of iron rich food through the diet. Okay, diversity, quantity, frequency under fortified food with the focus on harnessing the locally available resources. So locally available resources is very very important. Then next, ensuring the delayed cord clamping after delivery by 3 minutes in health facilities. I will tell you how the how the delayed cord clamping will help you in the uh, to prevent the anemia. Okay, suppose this is the placenta is not there. Okay, this is the baby. Okay, baby already came out. Okay, we need to check the cord pulsation. Okay, we need to check the cord pulsation. So, suppose once cord pulsation stop, we can cut the cord, or else we have to cut before up to 1 to 3 minutes. We can give the time. 1 to 3 minutes we can give the time. In that time only, should not cut the cord. So always, because this umbilical cord having the much of blood. Okay. So this, and also we should not milking the umbilical cord. We should not milking. Okay. Means we should not push the towards the baby's head. Okay. That may cause jaundice. How? So RBCs will break down and it will cause the jaundice. Okay. So we have to simply keep the baby. After delivery, simply keep the baby. Wait for 1 to 3 minutes. Once umbilical cord pulsation stops, we can cut the umbilical cord. Okay. So new essential newborn care also we will tell you in the upcoming video. Don't worry. And last thing, six institutional mechanisms. So this is the 6 into 6 strategy. So this is the six institutional mechanisms I will tell you. One is interministerial coordination and convergence with the other ministries and strengthening supply chain food and logistics and engaging national center of excellence and monitoring of the using AMB dashboard. AMB means Anemia Mukt Bharat. Then capacity building. These are the six institutional mechanisms. So 6 into 6 into 6. Don't forget. Okay. They may ask anything. Okay. Okay. This is very very important. Prophylactic IFA tablets as per the Anemia Mukt Bharat. Okay. This composition, all the exams they will ask. Okay. All the exams they will ask. What is the composition of IFA tablet? Okay, so always elemental iron will be 60 mg and folic acid will be 500 microgram. Don't forget 500 microgram. Okay, this is we are giving weekly. So we can refer this slide. Okay, don't worry, I will send you. Okay, so 60 mg plus 500 mcg, that is microgram of folic acid, will be given to the by the this one, but Anemia Mukt Bharat program. Okay. And question number 18. Consider the following. Consider the following actions under basic life support. Okay, then arrange them in a right order. Okay, see here, one is shout for nearby help, then check for the responsiveness and verify the scene safety get AED. So okay, now the basic life support is guidelines are changed now. Okay, we have to always verify the scene safety. Why scene safety is very important? Because suppose there is a fire accident, okay, fire accident or RTA, road traffic accident. Suppose there is an highway, okay. So here one accident happened, okay. So here also many vehicles are going, okay. Many vehicles are running here. So you are the first aid, okay. You are the first responder. Imagine, okay. So you cannot go directly on the road. Otherwise, you will also die with an accident. Okay. So first we have to do, you have to clear the traffic both sides. That is called scene safety. We have to clear the traffic, then we can move to the, then just we have to show our hand. Okay, accident happened. Just stop the vehicles like that. We can show here. We have to stop the traffic and we can move toward the victim. And suppose if there is a building, okay. So much of fire accident is happening. Now you are a first responder. You saw this. You can't get inside and save the people inside that house. Okay, you cannot. First, what you have to do? First, your safety is important. Okay, you cannot run into that building. Okay, so what you have to do? You can do if any openings are there, or else you cannot inside the building. You have to call the fire engine. Okay, that's all. So don't run after, as a first responder you should not run the any, okay, dangerous places. So scene safety is always first priority in the basic life support. Okay, so this will come the first basic, verify the scene safety. Then after that we have to check for the responsiveness. Yes, this is come to second priority. Then shout for the help. This is the third priority. And get the AED is the fourth priority. Okay, so which is the answer? 3 means 3, 2, 1. Yeah, this is the answer. B is the right answer. Okay, hope you understood. Then question number 19. According to Wang Baker pain rating scale, there are three pain scales are coming. I will tell you. Okay, everyone, everything I will explain you. Okay. What is the pain score of below given phase? Wang Baker scale also I will show you. So this is the 6. Okay, na pain score is the 6. After seeing the pace, okay, this is used for the children. Okay, I will tell you. See, this is the Wang Baker phases pain rating scale. Okay, so 0 is no hurt, 2 is little bit hurt. See, you can see the face and we have to give the score. Okay, so this is the hurts little more. Okay, then hurts even more, hurts whole lot. This is the worst. Okay, so based on this facial expressions of the babies, we have to give the score. This is the Wang Baker faces pain rating scale. Okay. This is a pain score, that is the 0 to 10 numerical rating scale. This is the numerical rating scale. This is the adult patient we are giving. Adult patient who are all able to understand our language. We can give this chart. Okay. So we can tell them out of 10, how much you are giving. How much out of 10, how much you are giving your pain score. Okay, we can ask. So he will tell that no pain, moderate pain, or worst possible pain. If he gives out 10 out of 10 is the worst pain, we have to think. Around if he gives 5 to 6, around 6 he gives, that is a moderate pain. Okay, so here they will take. Okay, here they will take. Patient will take here. This is the pain score. One more score is there, that is a visual analog scale. Visual analog scale, pain assessment scale. This is also, suppose if patient is not understanding your languages, whatever you are speaking, if patient is not understanding, we can use this method. Okay, no pain. Okay, so no pain is 0, mild is 1 to 3, moderate is 4 to 6, very severe is 7 to 9, and worst is 10. Okay, so 1 to 10 we can do the score here. This is a visual analog or VAS pain scale we are calling. The numerical scale, VAS scale, and the Wang Baker paces. Okay, and also other scales are there. We will explain in the next high yield topics video. Okay, then we'll come to the question number 20. Which of the following is not characteristics of high quality CPR? Which of the following is not a characteristic? Okay, this is very important. Yes, I will tell you what are the criteria for the high quality CPR. At least 5 centimeter depth of chest compression. Yes, this is must. And at least 100 to 120 chest compressions per minute. Yes, this is criteria. And avoid excessive ventilation. Yes, this is also. And change compressor every 4 cycle of cycle. Okay, this is wrong because up to 5 cycles we cannot move. 5 cycles we cannot move the water compressor. Okay, after 5 cycle only we have to reassess or 5 cycle or 2 minutes. So whichever is possible. Or suppose if compressor is exhausted, okay, whoever is doing the CPR is exhausted, we can exchange that. Otherwise, no. Okay. So here are the CPR quality is there. See, push hard, push fast. We say push hard and push fast. This is the CPR guideline. Push hard and push fast. At least 100 to 120 per minute and allow the complete chest recoil. Suppose you are pushing here. So this is the chest. Okay, you are pushing here. Okay, we need to allow the recoiling of the chest again. Pushing this our chest should be recoiling. Okay, then minimize the interruptions in the compression. We have to minimize the interruptions. That is very, very important. Then avoid the excessive ventilation. Should not do the excessive ventilation. Okay, then change the compressor every 2 minutes. I told you, no, every 2 minutes or sooner if fatigue. If compressor is exhausted, we can. Otherwise, if there is no advanced airway, that is to 2 compression ventilation ratio. Advanced airway means if there is no advanced airway, I will tell you. So advanced means in ET2. If patient is on intubated, so we can give one breath every 6 seconds. Here it is there. Okay, if the patient is intubated, we can give one breath in every 6 seconds. Suppose if patient is not intubated, that is 30 compressions, 30 is to 2. 30 compressions followed by 2 breaths we have to give. Okay, this is very, very important. Advanced and non-advanced. Advanced means suppose if patient is intubated means every 6 minutes we are giving one breath. Suppose if patient is not intubated, we are giving 30 compressions followed by 2 breaths. Okay, and also we need to maintain the EtCO2. EtCO2 will be always 35 to 45 range. We have to maintain. Okay, to reassess the, suppose if it is low or decreasing, we need to reassess the CPR quality. Okay, that is very, very important. Okay, so by this we will complete the session. Okay, so upcoming session will be say both included both MCQs plus topics. Okay, so don't worry before NORCET. Okay, before NORCET means we have time. Okay, we have time till September. Okay, 3 months we have time. So before that, we will finish all the topics, whatever we have promised in our high yield topics. Okay, so don't worry, our other faculties also recording the videos. So one by one, we will upload. Currently, we are uploaded only pediatrics. Pediatrics. Okay, so this also we will upload. Okay, and my classes I will upload both in YouTube and also in the app. Okay, but other faculties we will upload only in the app. Okay, my classes will be uploaded both in YouTube plus app. Okay, and other faculties will be uploaded in app only. Okay, overall purchase. Okay, test series, NORCET-9 mega test series, they will get the videos. Okay, so if you have any doubts, further doubts, or you need to cover a topic, you need a, if any doubts or you need this topic, you can comment. Sir, we need this topic. So you can comment in the comment section. Okay, thank you.